our speaker, let me remind you of the events this week. On Friday, we do not have a lunchtime talk, but we have the second lecture, the annual lecture series, given by Colin Klein from the ANU, who will be talking about transformers, speaking about deep neural network, representational structure, and the language of thought. If you're interested in Colin's work, we have a small reading group at 2 p.m. here on Thursday from 2 to 4. If you want to read the papers in advance, please send me an email and I'll share them with you. So we'll meet from here at 2 to 4 on Thursday with Colin. The next lunchtime talk is on Tuesday next week, given by one of our two postdoctoral fellows, Lucy James, and she will be talking about primordial black holes in perspective. And Bob Badaman will be talking Friday next week, also on deep learning correlations and the statistics of natural languages. I think that's why the Nobel Prize was given, I suppose, to Hinton and hopefully. All right. Today, it's my great pleasure to introduce Carl Hoefer. All of you know Carl. That will do my duties in introducing him. Carl, as you know, is our senior visiting fellow this year. We're extremely lucky to have him with us. He is the ICREA, I guess is the way you say it? ICREA, of course, yes. Research professor at the University of Barcelona. He has been a member of the very well-known Logos Research Group for now about a decade. He's also the director of the Barcelona Institute of Analytic Philosophy at the University of Barcelona. He is the founding editor of the European Journal for Philosophy of Science, now years ago, and we had the pleasure to work together at the time. He, as you know, he works in the metaphysics of science with a focus on physics. He has written extensively on space, time, motion, and so on and so forth, as well as the nature of objective probability. As you know, his 2019 book, Chance in the World, A Human Guide to Objective Chance with OUP, won the Lakatos Award this year, which is the most important award in our field. So that's congratulations, Carl, again. It's not the first time I'm congratulating you. This is not to be confused with the movie of the same title, A Chance in the World, 2017 movie. So if you're looking on Amazon, don't be misled with the movie. He got the Lakatos Award, not a prize for moving. And more recently, he's been looking at issues in objectivity in medical epidemiological research, which I guess will be somewhat the topic of today's talk. Carl, how is yours?
Thank you. So, thanks for the kind introduction, Edouard. And I just want to say I've been here about 6 weeks at the center now, and it's been just delightful. And I feel like I'm learning a lot and having stimulating conversations constantly, and it's wonderful. So thanks for inviting me to be here. Okay, so let me get on with this because with all my talks, the danger is that I go over time, not under. So here's how I got to the position of giving this talk today. Like many philosophers in 2020, when the pandemic hit, I just started paying a lot of attention to what was going on, the scientific things related to COVID and transmission and all that stuff. Unfortunately, in especially 2021 to 23, I observed with a kind of growing dismay a serious level of politicization. Is that the right way to say that? Of a lot of research related to COVID-19, and in many cases, a failure to adhere to minimal standards of rigor and impartiality as they were understood pre-pandemic. Now, I'll mostly keep that off stage today, because what I'm interested in is a kind of a reflection that came to me afterwards, and it might be something that will seem to a lot of you obvious, and why did it take me 30 years to get this reflection? But it's a kind of a reflection on the chaotic nature of the literature, in the first place on face masking to prevent the spread of COVID-19 and other areas of biomedical research, and that led me to the thesis that I'll be laying out today. More recently, I've realized that the concerns that I'll be talking about and their connection with causation are connected with some things I had written on in the past in certain ways. And I hope I'll have time to say a few things about that. So the plan of the talk real quickly is that I'll give you the thesis, go through a first example, which is a causal question about whether face mask mandates prevent the spread of viral illnesses. Second example, we'll look at, if there's time, is a very interesting study that came out just this past summer that created 100,000 or almost 100,000 observational studies, each one kind of very much like something you might have seen published in the scientific literature, looking at the non-pharmaceutical inventions to ameliorate the effects of COVID during the pandemic. Then we'll come back to my basic claim or my thesis and talk about it at a general conceptual level. Okay, so what is that claim? The claim is that, well, there are some generic causal questions that are effectively unanswerable. They're not unanswerable because of an epistemic limitation of ours, although there might be for that reason also, but actually unanswerable because all answers that you might give would be incorrect. If you answered the causal question, yes, there is this causal relation, you'd be speaking falsely. And if you answered, no, there is not this causal question, this causal link, you'd be speaking falsely. So let me try to illustrate how I came to think that might be the case. So the first case then that we'll talk about, our causal question will be Q0 here. Does mandating that the general public wear face masks of some type, which you can fill in the type that you'd like, surgical, respirators, cloth, any of the above, in indoor public settings, significantly reduce the rate of transmission of COVID-19? So that's our question. We'd like to know whether you can give a yes answer to this. No. To clarify, a couple of important clarifications. I think nothing much hangs on my use of the word mandating here. I mean, it's notorious that sometimes if you do a study where you're looking at the effect of a mandate, you find, okay, there's no effect, but it's easy to blame that just on the public's reaction to the government that's mandating. Here, the issue is mostly about whether getting the public to mostly wear versus mostly not wear the face masks is a causally effective intervention. Also, I had to put in the word significantly. I hope it's not being used in a sneaky or improper way, but think of it as some sort of low bar threshold, like, for example, a 10% reduction in the infection rate over a certain period or something like that. And I put that in there because I think without that, even if we could argue successfully for a positive answer to the question, yes, Q0, the answer is yes, but it might be insignificant. It would be of little interest to policymakers. That's what we're really interested in for this kind of causal question. Okay, and finally a caution, because I'll be looking at a lot of scientific studies and making some critical points. I don't want people to think that what I'm arguing for implies that properly wearing a surgical mask, or even better, a well-fitted respirator, does not protect the wearer and to some extent protect others from COVID-19 infection to some extent. That's nothing I will say in the rest of this talk implies that. In fact, I'll start out in a minute giving you some experimental data that supports this kind of potential protective effect. So I'm not trying to make some blanket anti-masker claim that masks never work or can't work. Okay, but governments really wanted and needed to know, and public health officials needed to know the answer to Q0. So let's look at considerations in favor of answering it with yes. And perhaps the most important consideration, I think, and we'll start there, is that there's an obvious mechanical plausibility because masks filter the air coming in or out of a breathing human subject. And so there's a kind of a mechanical, obvious story to be told there about it, how it could prevent infection. And later, so I'll show you a couple of such mechanical plausibility studies in a moment. From 2020 to mostly 2022, a whole bunch of studies also piled up in the scientific literature that seem to confirm the effectiveness of face masking. Notably, there were few RCTs. When it comes to the general public, actually just 2 done in the whole pandemic. And so these are almost entirely observational studies. Let's look now at the first study, which is kind of typical of the mechanical or lab experiment studies looking at this question, where you just put masks on mannequins and try to scientifically measure what's going on. So this one was done in Japan. Let me go to the next slide to make it a little easier to read. And it was a very interesting and I think complicated and well done experiment. They tried many different scenarios. First, look at what happens when the person infected doesn't wear a mask and the person receiving or potentially getting infected also doesn't. And then they looked at all the different permutations for mask wearing situations. And they basically tried to measure in the receiving mannequin, what's the viral load or the number of viral copies that ends up getting received in these various scenarios. And you can see the numbers down below. So these are sort of percentages. In the no mask case, you get 100%. That's the baseline. And then the rest of these quantities are normalized relative to the baseline. And so you see significant filtration happens, especially if you're looking at N95s, and especially if you're looking at ones that are fit. And by fit, here they mean taped to the face of the mannequin. Okay. The ideal fit possible. Okay, so that's interesting and indicative evidence. There was another study done in Canada using mannequins in a different way. This was an experiment looking at source control. So they were looking sort of a dummy that's going to be exhaling droplets that they mechanically manufacture. How much does the mask prevent those droplets or aerosols from accumulating in the environment? And they were looking at that over a period of hours, which is a nice way of trying to simulate what happens, say, in the workplace or a schoolroom or something like that. And here, the numbers are not as cheery, but of course they're looking at over a long period of time. And they came up with this number new here, which is the filtration efficiency of the different types of masks. And sort of relative to 100%, here you get 9% for the cloth masks, 12% for surgical. KN95s or basic respirators, 46%. R95s, which are the 3M kind that have double straps and are very expensive and almost nobody wore them. Those do much better. And then the interesting thing that these guys did in their experiment was what they put the mask on their mannequins, but left a gap around the nose or at the edge, just 3 millimeters, not a big gap, but to simulate what's more typical in the way people actually wear these things. And there, the filtration efficiency of that kind of respirator over time drops to 3%. So that's a really striking and important result. So can they be effective source control? Yes, at least over a limited time, but it has to be really, really tightly fitted. That's the kind of lesson from this. Here's a very recent, not too recent, but recent evidence review sort of wrapping up post-pandemic by the Royal Society, and they made their selection of studies to look at, and they plotted for you here the various outcomes. Here's a bigger view, so it's easier to see. They looked at three kind of categories of evidence: RCTs, randomized controlled trials of face masks in the public. There were just 2, like I mentioned. Down here we have observational studies for the public, community setting, and here we have studies that looked in the healthcare setting, in hospitals and so forth. And you see a whole very big wide range of levels of effectiveness. Almost all the studies favor masking as having some positive effect, but the error bars are big. and very often cross into the negative territory. So that's a kind of a mixed panorama that we get out of this kind of evidence. When you look at specifically the randomized controlled trials, I think it's a super huge shame that only 2 were done, and they were done with not the greatest budgets, not the greatest methodology, perhaps, and so, as I say here, these RCTs with the results they got were extraordinarily really fiercely criticized by both pro-masking people and anti-masking people, which is kind of interesting. But the magnitude of the effect is very small in both cases, and for one of them, it's by a long margin fails to be statistically significant. That was a study done in Denmark very early in the pandemic, May of 2020. Transmission rates weren't high, and they set up their experiment powered to detect a 50% reduction in infections by the face mask wearers. That was over optimistic. Okay, so those are kind of a bunch of considerations and evidence that we have out in the literature in favor of answering our Q0 yes. Now I'm going to spend a little more time presenting considerations in favor of answering it with no, and then later considerations for thinking that there just may not be a stable answer to this question at all. So first of all, if you look back prior to 2020 and just read the assessments of this kind of intervention by the World Health Organization, the American CDC, and other agencies in Europe and so forth, basically they're kind of down on the evidence for face masking being a very interestingly effective intervention for the public to do. I could show you a couple of summaries if you'd like to see from the WHO and the CDC.
You're talking about both protection and spread?
No, these are before. I think that most of the studies done before COVID were protection only. There may be some that were source control, I'm not sure, but they're mostly protection. Or mixed, kind of in checking both of it simultaneously. So both pre-COVID, when they were looking mostly at flu transmission, that was the topic that usually investigated, and post-COVID, if you just look at RCTs in general, which are supposed to be the pinnacle of the evidence pyramid in the health sciences, RCT evidence gives weak and or non-significant effect sizes in general, which is why the Cochrane collaboration, which you may have heard about, they're an organization that makes a business out of producing reviews of medical questions, the evidence, Cochrane evidence reviews. And before the pandemic, right in the early stages of the pandemic, and 3 years later, 2023, they haven't changed their basic conclusion. They almost exclusively look at RCTs, and they say there's no significantly good evidence in favor of the effectiveness. Here, more controversially, and I won't go into this in any detail, but from 2020 to 2023, the observational studies supporting masking, especially the ones that found very big effects, tended to be obviously flawed, to be subject to very evident confounders, or sometimes evidence that researcher selection of the time period for looking at the data, what study to do, and so forth, were playing a big role in generating results. And of course, a huge elephant in the room when it comes to these observational studies, they're not that expensive to do. They're usually not pre-registered. And so there can be a huge file drawer effect, which is basically that when you do one of these studies and you get a negative result, into the bin it goes. It never sees the light of day. Or maybe you do send it out to the journal, and the journal doesn't want to publish it. The Interestingly, the Denmark RCT masking study that gave a non-significant result was considered toxic enough by medical journals that they had to really shop it around to get it published. It took many months for the researchers to get that published. Okay, so we've already talked about the RCTs. Now I'm going to move to talking about just general plausibility considerations to think that the answer to Q0 may be no. And this is the biggest one right here. There's a huge variation in the way that people actually wear masks out in the community. And most of the time, they're wearing their masks with significant gaps around the edges. And the gaps vary very widely from person to person, from time to time, culture to culture. They grew greater as the pandemic wore on and the public got tired, and so forth. But so when you have those gaps in mind, then think again about that second mannequin study that I was pointing out, where even for the respirators, the N95s, the efficiency as source control dropped to 3% if you had a real gap involved, accumulated over time. Some more considerations. There's just the incredible causal complexity and the multitude of factors that affect viral spread, whether the virus in the air leads to an infection in a person. Now, there's some considerations or causal paths that are imaginable and were discussed to some extent that would actually indicate the opposite direction, that masking might be harmful instead of helpful. One is if people are constantly touching the outsides of their mask and adjusting them and so forth, and not washing their hands immediately, then the stuff that's being trapped on the outside of the mask gets on their hands, and then it's easy to see how that could lead to infection. And another big one was that if you have the whole public wearing masks and you tell them that they'll be well protected if they do that, they may more often go out when they're sick, or they're starting to feel a little under the weather, but they're not sure yet, or they just may feel safer in general to stand next to someone and have Spanish people are like this, and I've picked this up. So if I stand too close to you in a conversation, just tell me. The Spanish people stand really, really close and talk at about this distance. So if you feel you're totally safe and you do that, that's going to be an undermining factor. If you're wearing a mask and you feel it's hard to breathe, you're going to be breathing in and out harder, which reaches deeper into your lungs and may produce more aerosols. And finally, a very interesting mannequin type study that I saw early in the pandemic. Some researchers took a whole bunch of different cloth masks and studied what happens to the mannequin exhaling through them. This was still when the medical masks were not widely available. And certain kinds of fabrics that people were using, actually all they did was turn droplets into aerosols. It basically made the particles smaller so that they hang in the air for longer. So that's not good. So now let me mention considerations just for thinking that the whole thing is very unstable. That I've already mentioned there's a strong culture dependence in mask wearing behaviors, and it's sensitive to many things. One thing that I think people in America should be sympathetic to is that whether someone like Donald Trump endorses or opposes or implicitly opposes that everybody should mask up may have a significant effect on people's behavior, both the people who like Trump and the people who don't like Trump. But that's obviously an enormously contingent fact about this pandemic, and there are other people that might have an effect on people's mask and wearing too. What does the media say? What do people read in social media, Facebook and Twitter and so forth? This has an impact, and it's contingent, medically speaking. The popularity or unpopularity of the government that's currently imposing the mandate matters a lot. And all of these factors depend sensitively on other factors in turn. And all of this makes me think that there's not really much counterfactual stability that lets you export from one situation to the next, a kind of a reliable causal prediction. I think that what happens in any given context when a mandate goes into place, or just a recommendation even, is that it's dependent on initial conditions. The results will depend on the prevalent infection rate, on how tired or receptive the public is feeling, and even on chance events. So it was kind of discovered that an early big outbreak in Korea was largely started by one woman who was a super spreader and went to church. And then from there, the infections radiated very quickly. Another issue, which really is too hard to study because the variants of COVID-19 emerged one after another too quickly, starting in 2022 at least. But maybe it makes a difference which kind of variant virus you're looking at, how effective. Okay, so I'm going the wrong way. So what I've been arguing for is a kind of a truth value gap in that I'm saying neither this should be endorsed nor this. Neither that it significantly reduces the rate of transmission, nor that it does not significantly reduce. Neither of those should be endorsed because each of these, we want to be able to interpret them as a stable, reliable causal generalization, and I think they're just not. That's not a truth value gap in any interesting logical sense. I say this is false. I say if you put ahead of this, it is not the case that, then it's true. It's more like this. You know how we're in election season, so this occurred to me. Pundits on CNN and other media tend to say really silly things at times like, you know, in the past 20 elections, so as goes Pennsylvania, so goes the nation. And then they talk about Pennsylvania for a long time. But obviously neither of these is a true generalization. Okay, we're doing okay-ish on time. So I'm sorry if I feel like I'm rushing. This is a very interesting second example that I want to talk about, and I'm really not entirely sure that I like the study or that I'm ready to endorse it, but let me lay it out anyway. This is a big data effort, and basically what the researchers did was grab all the data that is widely available, publicly available data from countries around the world. They looked at 180 different countries, gathered this data about things like rates of death from COVID, excess death compared to pre-pandemic, infection rates, and so forth, and how those correlated or not with various government interventions. And they looked at a whole bunch of interventions. And they just generated, by permuting all these kind of combinations of things you could look at in the data, 99,786 different observational studies. It's an incredible thing. And here's the beginning of their discussion. So we perform a multiverse analysis of nearly 100,000 ways of probing the relationship between COVID-19 government responses and outcomes in 181 countries. So they created a whole bunch of analyses and assessed the sensitivity of the results to the choices made by governments. In the study, we found no clear pattern in the overall set of analyses or in any subset of analyses. We are left to conclude that strong claims about the impact of government responses on the COVID-19 burden lack empirical support. So to give you a flavor of what they were doing, here's the permutations that led to those 99,000 something. They looked at 19 different kinds of policies, or not all of them really should be called interventions, but some of them were like giving economic support to businesses that are temporarily closed. They looked at 9 different types of outcomes. They created 6 different models that they applied for analyses, so different analytic techniques for creating their observational studies. They looked at 3 different periods, 3 different time frames, 2 weeks, a month, and go with the longer one was, and so forth. So here's some things that they said further down in the discussion about their motivation. No government studied its responses directly with trials or experiments. As a result, one common thread is that the data available for studying policy responses are messy and complex, resulting in analyses that may also be complex. Existing studies of COVID-19 response impacts range from unrealistically positive to unrealistically or dismissively negative, further complicating an assessment. So they present it like there hasn't been a good global analysis done of whether government interventions worked. So they're trying to advance the science of government responses. They say that their multiverse analysis elevates epistemic humility by relaxing the number of subjective choices in the design process. And they say further down, we take this approach because data available for analysis are complex and rich, making possible a large number of plausible analyses, and we aspire to limit the role of data and model choices in driving the results, or researcher degree of freedom. And that right there just means all the different ways in which observational studies can be crafted and tweaked by their creators to get a desired result, which is well known to philosophers of medicine, especially, and social sciences. And it's the reason why the traditional evidence-based medicine hierarchy puts them lower down than randomized controlled trials. So the vast majority of the studies they created don't reach significant statistical significance. Those that do, for most causes and most outcomes that studied, about half of the studies support effective and a half support non-effective. And to me, and this is the reason I'm telling you about this big study, it seems like exactly what you'd expect to see if there are no true causal facts out there, and you go and try to look for the causal facts anyway. The authors did what they call a plausibility analysis. They applied their technique to historical data about measles rates in the United States, and what happened when in the various states the vaccines became available. And those results were overwhelmingly positive, overwhelmingly statistically significant. So the scenario was quite different. Okay, so these are just a couple of quotes where they say things that I think are really interestingly similar to the thesis that I've been looking at today. Let's see what I want to pick out here. We can't conclude that there's compelling evidence to support the notion that government responses improved COVID-19 burden, and we can't conclude that there's compelling evidence to support the notion that government responses worsened. And that's in line with the non-existence claim that I'm studying here. In case you're interested, we can come back to this discussion. This breaks down by the kind of outcomes they studied, what happened, sorry, and which policies seem to have the most significant or least significant results, and so forth. But I won't go into that now. So let's go back to the thesis. My claim is that some questions, generic causal questions, are effectively unanswerable, not because we just can't find the answer, but it's out there, but rather because there's no correct answer out there. And extracting lessons from the biomedical context, what seems to me to characterize when this happens? Well, you've got complicated causal systems with a lot of moving parts. You have sensitive dependence of an outcome in a given case on initial conditions that aren't included in the description of the cause. There's sensitivity during the unfolding of the effect to outside perturbations or to chancy events. And most importantly, human beliefs and desires and actions play a huge role in whether the cause is effective or not. Really, this impact of human action and human intentionality on what happens seems to me to be very important and unfortunately ubiquitous in sciences like economics and other social sciences and in biomedicine. This is just kind of a funny analogy. Some of you may be familiar with Janan Ismail's book, How Physics Makes Us Free. And one of the chapters discusses how, what about determinism and are our actions really unfree if physical determinism is true? She says, look, there's this thing called the paradox of predictability. Even if a Laplacian demon has predicted somehow based on the initial conditions of the world that what you are going to do 10 minutes from now, if the demon is required to honestly tell you what its prediction is, you can thumb your nose at the demon and say, you know what, I'm not going to do it. Now, the use that Janan makes of this example in her argument is it's complicated. It's a very interesting conundrum, and that's not really the point here. But my point, why it resonates with me, is because with causal interventions where humans are involved, it's kind of like that. Human intentionality, desires, and beliefs play such a huge role that no matter how carefully you think you can understand or control the causal forces, the humans can disappoint you, whether intentionally or unintentionally. Okay, now, forgetting about specific features like that, I wanted to mention a couple of ways that this connects with traditional approaches to generic causality and sort of philosophers' approaches to understanding causality. And the first thing has to do with probabilistic analyses of causation. Right? That's a very common technique used for these kind of phenomena, where you think that when certain probabilities are in place, there's a causal structure that is reflected by those probabilities, and so we can extract causal conclusions from the probabilities, and that probabilistic structure is what really constitutes the generic causal truth in that area. Well, the problem with that is, well, over the past 2 decades, I developed a view about objective chance, a Humean story about what objective chances are, that entails that there's just, by comparison to what a lot of philosophers believe, there's a lot of chance gaps out there. There's a lot of failures to simply exist of any objective probability, even when there's statistics to be had. So, and now, if those of you who are familiar with this very old and famous article by Nancy Cartwright called Causal Laws and Effective Strategies. Beautiful article. Young people, if you haven't read it, you should read it. And in that article, Cartwright is discussing what's the connection between probability facts and causation, general causal facts. And she comes up with a principle called CC. We don't need to look at the details, but in that principle, it says C is a cause of E, like mandating face masks as a cause of reduced infection rates, if and only if the probability of the effect given the cause and holding a whole bunch of other stuff fixed. So these KI range over all the state descriptions, meaning permutations of other causes that are relevant to the effect, which you would want to hold fixed if you could study it ideally. If the probability goes up in all those different contexts, basically. That's principle CC. And then what I came to think is that the problem is that in many cases, there's so many other causal factors that can be relevant, so many different permutations that, well, if you're like Cartwright and you believe that laws of association are just the statistics in the world, actual frequencies, then once you start looking at conditional probabilities, in reference classes that get narrower and narrower and narrower, you'll easily get down into reference classes that have 1, 0, 2 people in them. And then the statistics don't mean anything. Nobody would say that those are objective chances anymore. My own view about objective chance entails that the failure may come even much more simple levels. Okay, so if there's chance gaps, that's one reason why, well, if there's really just no objective chance about what happens with an intervention E, intervention C, that's one kind of metaphysical problem that might be lurking underneath the issues we've been talking about. Thinking things in terms of counterfactual approaches to causation. I talked a lot about instability of the whole systems and what happens with the interventions and the different systems from one context to another. And that instability, I think, leads to a failure of existence of counterfactuals also about what would have happened absent a certain intervention. So many philosophers like to think that there's always an answer to a counterfactual question, like what would have happened had C not been the case. I don't think that there is always a fact of the matter. So I mentioned that a lot of times there's a sensitivity to the details of the way the actual intervention is done, but also the counterfactual absence. And I wrote about this in a paper in 2004. Just think of it in terms of a simple single case, in terms of like Lewis's theory of causation. You think, okay, C caused E. Now I want to look at the nearest possible world where C was absent. Well, you have to give very specific physical description of that world. But at a type level, at the level of type, like strike a match, there's no single description. And if you take some initial conditions and put it there, you won't get the effect, and some will. I think something similar happens even at a generic causal level too. So think about a given case when face mask mandate was put in place. What would have happened absent that intervention? Well, how are you going to model the absence of the intervention? How far back are you going to go in sort of the public discussion around it, or the decision making inside the government, and so forth? And all these things might actually make a difference to the outcome, even if there's determinism at work in the physical world. Finally, I want to give a mention to Alan Hayek, who thinks that most counterfactuals all the time are false, which is a kind of a way of saying, emphasizing this point. If there's any kind of chanciness or instability of what you do in the counterfactual, when you remove a cause, there's no fact of the matter. Okay, just to wrap up, let me mention some possible objections you might have and how I respond. First, I would expect defenders of the traditional approach to evidence-based medicine to say, look, all this stuff you've shown is just an epistemic problem. The problem is we didn't do enough good RCTs, and if we had, we'd know the answer. I still think not necessarily. I mean, I do wish more had been done. I think it would have been instructive. I also think that they would have given results largely similar to the ones that we saw before the pandemic. But even so, what I've tried to give you in terms of plausibility considerations and looking at the literature, to me indicates that there's no guarantee that if we did a lot more well-designed RCTs, there would be stability looking across those RCTs, or if we sort of repeated the same RCT at different times in the same population. There's no faith that you get the same results. Okay, second one. I still think that many people might want to say, no, look, but in any concrete situation where a causal intervention is contemplated, isn't there always going to be a clear counterfactual answering the corresponding specific question, what would have happened without the intervention? And I already argued a minute ago, I don't think that's really the case. But even if it is, of course, in general, that what would have happened in these complex systems is going to be unknowable. And so it won't be able to guide us in policymaking. And I think in general, even if there is always an answer in a very specific case, I don't have any reason to think that the answer in the case down the road or in another country, the answer is going to be the same. And I started to wonder, I haven't even thought about this, but I started to wonder whether this might be one of the factors that's at play in the replicability crisis in social sciences and in psychology. You all know what that is, right? The meta studies looking to replicate earlier studies out there in the literature tend not to find them to be replicable. The results don't. Okay, just to conclude, I put up here the things I just told you. You don't need to be reminded, really. And so I just want to say thanks for listening. I look forward to a discussion.
Time for question, but we'll take a 2 or 3 minute break. And I just already see hands.